Hello and welcome to another edition of the Osteopathic Lyceum podcast. We're going to go through another educational standards document. So while with respect to the osteopathic profession, this may not be the most exciting for everybody, with my particular background in health science education, these are quite interesting to me. They do matter to people who are in the profession or looking to get into the profession because these are the documents through which training will be guided. If there are issues with these documents, then a lot of the administrative tasks and a lot of the educational delivery can then contain any flaws that exist within these documents. What I'll say is that regardless of the document or the guideline, it's pretty normal, common, and consistent that you will have pretty good educational outcomes and pretty good practice outcomes regardless of the framework. So generally speaking, if you assay the profession, people are doing pretty good work. They say absolutely crazy things, as I consistently note, but the work is pretty decent. So once again, the thing that I am going to do is I'm going to read through the document, but I'm not going to put it up on the screen. One of the reasons is I do think it's valuable for you to have to go find some of the stuff. I also think it's valuable to not increase your cognitive load by having you pay attention to the document and listen. Now, that said, in video format at least, it's reasonable to assume that you could pause and read and then restart the video. I just don't know that a lot of people do that. I think more likely people just let it play through, and if there's too many things to catch their attention, it's a bit of a problem. So the document that I'm going to read through, at least portions of, is osteopathic healthcare provision, main element, complementary element. That's not right. That's not the proper title. What's the proper title? It is a CEN document. I think it's consumer something, European network, something like that. There is a similar document that is based on this for the Canadian context. It's, I think, the CSA document, but it's essentially jumping off from the World Health Organization benchmarks for training in osteopathy document and adding a little bit more. Okay, so I'm going to go through very specific things. Nope, I don't need to do this. Oh, actually, this is important. So within the foreword, this ends up being on page 5. This document, I'm not going to read the numbers, has been prepared by technical committee, not going to read the numbers, Project Committee of Services in Osteopathy, the secretariat of which is held by ASI. This document is currently submitted to the formal vote. Attention is drawn to the fact that in certain countries, specific national regulations apply and take precedence over this European standard. Users of the European standard are advised to inform themselves of the applicability or non-applicability for this European standard by their national responsible authorities. So something that I consistently note, especially with respect to particular methods, especially thrusting methods, there are different regulations around practitioners in different jurisdictions, and you have to pay attention to those. What I will say is that if you're going to generate a document that everybody should follow, it should be abstract enough that it doesn't cross any boundaries and then you add on those boundaries. So it should be at a fundamental enough level that you add things depending on jurisdiction. You don't necessarily take anything away depending on jurisdiction. I wouldn't say that there's anything taken away based on varying jurisdictions. I think things would be added based on regulations in particular places. So that's totally fair. I just wanted to note that within this document, this European standards document for training in osteopathy, there is the note that there will be variation jurisdiction to jurisdiction. This is not necessarily something that I recall seeing in the benchmarks for training in osteopathy from the World Health Organization document, which really is a region of Lombardy document in Italy. Do I want to read that? Nope. I am not going to read that. I'm going to scroll quite a bit down. I'm going to look, this ends up being on page 10, the clinical practice, so 4.1. So I'll read this. Osteopathy is focused on the patient's health rather than being disease-centered. Osteopaths shall have an understanding of osteopathic and non-osteopathic models of health and disease and how these inform a critical consideration of practical patient care and management. They shall have a critical awareness of relevant research and of principles and practice of relevant healthcare approaches for adequate referral, cooperation, and adjuvant treatment. I don't know why the word critical is in there so much. That is a bit of a red flag for me for reasons that have nothing to do with osteopathy, but the critical term, that's an interesting one to me. That can be thrown out as it stands, I think. I don't think I need to worry about that. The basic concept of osteopathy being focused on health as opposed to disease. That's one of those philosophical points. If you observe osteopathic practitioners working, they are actually concerned with mechanical dysfunction. Whatever stories they want to tell, whatever rationale they want to use, is just the story and the rationale. The actual things that are identified are mechanical dysfunctions. The actual things that are interacted with are mechanical dysfunctions. The actual things that are changed are mechanical dysfunctions. It's mechanical dysfunction all the way down, regardless of how somebody wants to talk or think about it. So I don't know that I properly agree with that. I don't have to properly agree with that. I just need to note that I think there's a mistake there. So anything that you build on top of that, if it is a mistake, and I may be wrong, if you build anything on top of it with that particular concept, then it must respond to that appropriately. So health-centered versus disease-centered, that's a weird philosophical dichotomy. If you actually observe osteopathic practice, osteopathic practitioners are looking at mechanical dysfunction. That's what they're doing. So I would hazard to change that for good reason, or what I would consider good reason, and it's possible to argue my point. So to look at section 4.2, there is a section called Essential Competencies for Osteopathic Practice. There's going to be a long list, and some of it will be redundant and some of it will be ridiculous. So I will read now. Osteopaths share a set of core competencies that guide them in the diagnosis, management, and treatment of their patients and form the foundation for the osteopathic approach to healthcare. The following are essential competencies for osteopathic practice, which should include all training programs. And it says C6.3 below. Okay. So competency A, osteopathic history, principles, and approach to healthcare. There's not a competency there at all. That is asking for particular details to be regurgitated. There's no competency. That's memory. B, basic sciences relevant to osteopathic practice. So the question would be the definition of what relevant would be, what a basic science would be. Really, what you're probably talking about is anatomy and physiology specifically. So fair enough, but they don't say that. They probably leave it open so that there's some interpretation. I don't know. Diagnosis and treatment planning, that's a competency. So that's C. D, knowledge of the mechanisms of action of manual therapeutic interventions in the biochemical, cellular, and gross anatomical response to treatment. I don't know that I would call that a competency. I think that because it's not a behavior, I would call that much more a knowledge requirement. So if you demonstrate competency with that, what you're demonstrating is that you know the stuff. So I wouldn't call that a competency. E, the ability to appraise medical and scientific literature critically and incorporate relevant and contemporary information into practice. So knowledge translation is what they're talking about. Knowledge translation would be a competency because there is a behavior. You're taking information and taking it from one place and putting it into another, whether conceptually or physically. So that would be a competency, and you can assess that. Competency in a broad range of osteopathic skills. Okay. I skipped one. Please excuse me. I'll come back to that with probably the same reaction. So F is competency in the palpatory and clinical skills necessary to diagnose dysfunctions in the body with an emphasis on osteopathic diagnosis. So osteopathic diagnosis, that's a weird term. And this is coming from somebody who's an osteopathic practitioner. Competency in palpatory and clinical skills. Okay. So that's not one competency, that's many competencies. Palpatory identification would be a construct. You would have ways to identify that, ways to measure that, ways to interface with that, ways to teach that, and assess, whatever. The clinical skills, which ones? So each clinical skill would probably be a competency on its own. You could make a broader clinical skill box. You could do that, but there will be hallmarks for what that looks like, so you would be able to appraise that. So that really is more than one competency, but they've placed it into one. Going back to G, competency in a broad range of osteopathic skills. Well, F got that, so whatever. It's redundant. Also, what are osteopathic skills? Please define. H, proficiency in physical examination, understanding of relevant tests and data, including diagnostic imaging and laboratory results. The F is osteopathic diagnosis, so proficiency in physical examination, that's in F. Understanding of relevant tests and data, I guess knowledge translation, so that's more knowledge, including diagnostic imaging and laboratory results. That's a little bit more knowledge based, so I don't know that that's a competency. So that one's a little funny, but more of that is in F. So you see how when you have a construct or something that is identifiably itself and not other things, and then you can sort of build stuff on top of it, or you can have many things that dissolve into the same thing. In this case, we're seeing a bunch of stuff that dissolves into palpatory and clinical, or palpatory and diagnostic, right? So yeah, there's a lot of stuff that's kind of zooming in and zooming out that's redundant for nothing. Understanding and expertise in diagnosis and osteopathic treatment using osteopathic models. So the osteopathic models are interpretive steps. You can watch some previous videos that I've done. The osteopathic models are interpretive steps. They are not behavioral. You find things and then you think about them and then you put them into the appropriate model: respiratory, circulatory, biomechanical, whatever it happens to be. You just put it into that model and you use it as an explainer, even if it's wrong. So that's not a competency that's, I would say, is worth considering or keeping. J, thorough knowledge of the indications for osteopathic treatment, contraindications specific to osteopathic techniques. So indications, contraindications. What I would say is contraindications are much more important because it tells you what not to do. Indications for particular methods are probably a lot more amorphous. Plus, each individual is going to be so different that you're going to have a way to figure out what works for that person, which is why I use a heuristic model. So I would say that contraindications, absolutely testable competency, because it will look different depending on the person. The presentation will be quite different for contraindications depending on the person. So that is something that you'd want to assess because that's a safety thing. The indications, if there are no contraindications for something, then it is essentially indicated, but each individual will respond differently. So that's where I think that's less of a thing. That could fall back into essentially treatment choice, right? Method choice. So there, you could set up different competencies for that. Okay, ethical and legal aspects of healthcare. The ethical and legal aspects, I don't know that that's a competency per se, but it's exceptionally important. You need to know the legal framework under which you exist and ethics. So beneficence, non-maleficence, autonomy, and what is justice? Justice. Yeah, I think that's what it is. I may be messing up the term, but essentially you're going to have to apply treatment to those who need it the most and essentially use a triage model. So that matters. The L, a basic knowledge of commonly used conventional medicine, complementary and alternative medicine. That is much more about the ability to refer, so identify when your approach is going to be useful, when somebody else's approach is going to be more useful. So you have some understanding of that. You could call that a competency. It's more of a knowledge-based competency. Yeah. M, a knowledge of practice, financial and data management and regulation relevant to osteopathic practice. The regulation, you could put that more ethical and legal, right? So you can see how sometimes people like lists for the sake of lists and they don't actually figure out groundwork constructs to then build competencies around. And self-awareness and the ability to be self-critical, to be able to respond positively to feedback from patients and peers. Show me how you measure that, especially in an educational setting. It's not impossible, but that's going to be hard, especially for the reality that some people will know how to appear like they can do it and not be able to do it. Yeah, good luck with that one. 4.3, I'm going to move on to another section. Please excuse me. Ethics, education and training. This is section 6. This starts on page 13. There's the forms and categories. Forms and categories. 6.2.1 general, I'm reading now. Regulating the practice of osteopathy and preventing practice by unqualified practitioners requires a proper system of training, examination, and licensing. Benchmarks for training have to take into consideration the subsequent items: the contents of the training, the methods of the training, to whom the training is to be provided and by whom, the roles and responsibilities of a future practitioner, the level of education required in order to participate in osteopathic training. There are 2 types of training depending on prior training and clinical experience of trainees. Type 1 training programs are aimed at those with little or no prior health care training, but who have completed high school education or equivalent. And type 2 training programs are aimed at those with prior training as healthcare professionals. So this mirrors what has been set forth in the WHO Benchmarks for Training in Osteopathy document from 2010. Please excuse me as I take a sip. Okay, so now we get to section 6.2.2. Common features of both type 1 and type 2 programs. So remember, it says common features. Both type 1 and type 2 will do these things. To read, osteopathic manual treatment is a distinctive component of osteopathy. It requires both cognitive and sensomotoric skills. I'm not sure that's a proper word. I'll take it though. Sensomotoric skills and knowledge, and the development of these clinical and manual skills require time and practice. Osteopathic skills and physical examination training shall be delivered via direct contact. Other academic curricular content may be delivered in various training formats. Both type 1 and type 2 programs shall be externally validated or assessed with independent and expert osteopathic input. Providers of osteopathic education and training shall ensure, through documented information, that clinical and academic staff have appropriate professional and educational knowledge, skills, and experience maintained with continuous professional development. So I'm going to pause here. That piece, the external validation, I would hazard to suggest to you that at least in some areas, there is very little external evaluation of programs. It doesn't mean it doesn't happen, or it hasn't happened, or it won't happen. But right now, I think the external validation is minimal. External validation doesn't mean something's valid. It means you hit whatever bars they put forth. So if those are administrative bars, then that's what you've done. As far as the actual provision of education and the skills, that's tougher. There's a value there that I think matters to actually have people check, but I would hazard to suggest to you that many places have not done as much of that unless they are housed within other institutions. So a program that is housed within a college system or university system probably has been validated, maybe not by an external source, unless the university or college hired an external auditor who probably doesn't know what they're doing, or they did it internally and then they only know what to do on the administrative side, not necessarily the osteopathic side or the provision of that particular form of education, or provision of education for that particular applied field is probably a better way to say that. So whatever. The continuous professional development for the educators, that is interesting because I don't know that there are necessarily appropriate places for that to happen with specific respect to the applied field. With respect to actual provision of education, there's plenty of opportunities. Continuing professional development, continuing education units, however you want to say that, has very little evidence that it's effective. It has evidence that it is done. It does not necessarily consistently display behavior change subsequent to provision or engagement with those activities. So I would say you'd want to go another step farther and add in evaluation of improving skills. They would, I believe, assume that that would be done in-house, but I don't know that it's there. So you really want to acknowledge that continuing education models sort of don't work. And many professional organizations around the world have recognized that and are attempting to do something about it. One example is some of the changes that have occurred with the the College of Massage Therapists of Ontario, CMTO. They've changed their continuing education framework. I don't know that they're done, but they're changing it. They may still be in process, but they recognized that the general CEU model, like this many credits per this unit time, is what you have to do, and then that will do these things. And it didn't do any of that, so they've changed it. They recognize that. So that's kudos to them for that. Maybe the current model is not appreciated by everybody, but at least they recognize that there's an issue with it. So to go back to reading, this is very, very important. Supervised osteopathic clinical practice is an essential component of the training of osteopaths, which may take place in several formats. The majority of clinical training shall take place in an osteopathic environment. Suitable formats include a dedicated osteopathic teaching clinic where high-quality clinical support and teaching can be provided. So that's A. B. In medical hospitals or in healthcare establishments where students are able to observe a wide variety of pathologies and standard medical treatments and to train in interprofessional communication. C. In school-approved private osteopathic practices where students are able to observe, diagnose, and treat patients under supervision. D. In a teaching environment where students are able to observe how an osteopathic lecturer performs a treatment of a patient and reflects the process with the students. And E. In a teaching situation where students may treat patients in front of students, supervised by the lecturer or table trainers, and with patient consent. The student shall undertake supervised osteopathic clinical practice within a dedicated teaching clinic. It is required that in all programs, the student shall perform osteopathic treatments in a dedicated clinic on no fewer than 50 distinct patients in order to be trained in a variety of presentations during their education. This includes taking the initial case history and examination, making a diagnosis, and formulating and implementing an osteopathic treatment plan for the patient. Okay, so what you can see is there are multiple formats. Those formats do not necessarily dictate that you have to do all of them aside from 50 individual patients for a particular practitioner or student. So that 50 is the number that they've set forth. No rationale as to why it's 50 aside from a variety of presentations. That makes the assumption that the presentations will be variable enough that they will be notable. That's actually a really hard thing in healthcare training, getting enough people with enough particular things that people actually see the thing that they're supposed to see. You can't easily do that. That's a real problem. I would argue that the ability to work on a variety of people, regardless of presentation, and practice technical skills whereby you get a particular area to do a particular thing in a particular way, you work on a skill set, would probably do most of what you would want. There are major challenges with the concept of simulation and the concept of particular presentations within healthcare training. Simulation, some people argue that it should be as high fidelity as possible. There are certain things where we can prove that really, really low fidelity simulation, first of all, does better and is way more cost effective depending on the exact thing that you're talking about. With respect to experiencing a bunch of different presentations, that's a weird one because within osteopathy, you're not treating conditions. You're not allowed to. And you're not treating disease according to this document. You are treating health, right? It's a health-based model. In that health-based model, if you listen to what I've said, what you're identifying is mechanical dysfunction. So if you can find mechanical dysfunction and deal with it, you can find mechanical dysfunction and deal with it. If you can find it in particular areas and you work on it in particular areas, and you learn how to be responsive to whoever's in front of you based on whatever presentation they have, that's the important skill set, not how do I deal with this presentation. It's how do I deal with any and all presentations based on a framework. So I would have reason to accept the number 50. I don't think I have a problem with that, but I don't think that's going to guarantee any of the outcomes that this document would want. This document is asking for some stuff that I don't know they understand properly on the training side. Maybe they do, maybe they don't. I have my thoughts and beliefs, so whatever those ends up being worth. I don't think it's going to do what they want it to do. I think a framework-based model works better. I think being able to work on a variety of different people on any given piece of anatomy and get it to do exactly what you're wanting it to do. So either get it through the restricted range without it tightening up, right? Going direct without making them say ouch, making the particular piece of anatomy go soft, the soft tissues go soft, and going indirect, and then working that over and over and over, regardless of presentation. So no matter how somebody presents, I can get this thing to do what I want so that when it does present, I can do exactly the thing that I want to do. I think that's more appropriate. But yeah, to go back to B, some of the training can happen in medical hospitals or healthcare establishments where students are able to observe a wide variety of pathologies and standard medical treatments and train in interprofessional communication. So that's where, if you look at certain schools and their practical requirements, they make you shadow people of other professions, and then they make you shadow people within your own profession, and that's part of your clinical hour set. So it's validated there, it's there. Think of that what you will. So I am going to quick read through 6.2.3 and 6.2.4. So 6.2.3 is type 1 programs. Typical type 1 program, as defined by the World Health Organization, benchmarks would take 4,800 hours, including at least 1,000 hours supervised clinical osteopathic practice and training. Models of higher education, including definitions of teaching, learning, and contact hours, vary across countries of Europe, and the requirements of type 1 programs shall meet no fewer than 2 of the following 3 requirements. No fewer than 4,800 hours. You don't have to do that, but you want to. No fewer than 240 European credit transfer system credits and a minimum of 60 ECTS credits at the level of the second cycle. So you don't have to do that one, but that's one of three. C, a master's level qualification, whether or not preceded by a separate bachelor's level qualification. So yeah, that's an interesting thing. So they're very concerned about the total amount of hours. You could maybe be less than those hours if you get B and C. Hour counts don't mean anything aside from hour count. So yeah, you were there for that long, in front of people for that long. It doesn't prove competency. They do actually in this document have some assessment, which I think is actually a giant leap forward. It's very important. So type 2, so 6.2.4, the length and content of a type 2 program shall be adapted depending on assessment of the prior education, training, and experience of the student. It is required that the type 2 program shall include a minimum of 1,000 hours of supervised osteopathic clinical practice. However, the number might be adapted depending on the range of prior training formats as described in paragraph 6.2.2 above. Typical type 2 programs would take 2,000 hours over a minimum of 4 years, including supervised clinical practice and training. The osteopathic learning outcomes for a type 2 program shall be the same as for a type 1 program. Type 2 programs shall cover osteopathic core competencies, including knowledge, understanding, and application of osteopathic models. Regardless of any prior education, training, and experience, graduates of type 2 programs shall also demonstrate the same practical competencies of osteopathy, including sensomotoric skills and the application of osteopathic principles in clinical treatment as graduates of type 1 programs. So what I'm going to do very, very briefly is I'm going to press pause on the video just because of how I have this set up, and I'll come right back. So to be fair, I didn't need to warn you about the edit, but I think there's some value just in showing that there's continuity of what I'm doing. Anyways, returning to the document, we've gone through the type 2 program. The thing that I want to note with respect to the clinical side, if somebody has some previous healthcare, like it's got some really interesting weasel words in there. You're supposed to assess the previous competencies. So if somebody comes from a clinical environment, why the heck do you need to watch them or have them do 1,000 hours of osteopathic quote unquote stuff? I don't know. That's interesting to me. If let's just say somebody's been a nurse or a massage therapist, the clinical side is probably already mostly taken care of. You need to work on the manual skills and the interpretive set. So realistically, you need to embed the concepts into them that will guide the behavior that would be considered osteopathy, which really is primarily the actual physical application and interpretation of the barrier concept, because that's the main difference between osteopathy and any other profession. So that one is tough for me. Also, the 4 years, I don't know why it has to take 4 years. I think they're making the assumption that somebody's going to be working in a particular way that you couldn't get the amount of hours in less than 4 years. I don't know what that is. That seems very strange to me. I would be interested in the decision-making process that was occurring there. But anyways, to read 6.3, which is the core competencies, the content of osteopathic education. Okay, so A, basic science, history and philosophy of health sciences. Yeah, I think I'm okay with the philosophy side of the history. Yeah, fair enough. Gross and functional anatomy, including embryology, showing the link to osteopathic understanding and treatment, neuroanatomical and visceral anatomy. This is an interesting thing to me. Embryology and connections to things are legit. The osteopathic understanding of those things doesn't seem to hold much water. If that is known and knowable, it should not necessarily be there in that way. You could just leave it terminologically at the understanding of embryology. It's a strange fetish within the profession. Everybody was an embryo. That doesn't mean the things that happened in utero when you were an embryo are the root of all of your problems. You change over life. You adapt. It's a strange fetish. I don't know that it needs to be there as a highlighted thing. People will argue for it. I would argue that people are just being weird about it. So next one to read again. Microbiology, biochemistry, and cellular physiology. Physiology. Why? I don't know why that's separate. To read again. And biomechanics and kinetics. Microbiology, sure, I guess, just for understanding biochemistry. Sure, I guess just for understanding, osteopathic practitioners do not interact with it directly, and the only way that we interact with it is either our patients are being managed on those levels by an appropriate practitioner, or to whatever degree there is a mechanical dysfunction that is impacting those things. We only find the mechanical dysfunction. If we change mechanical dysfunction, those things may change due to different external signaling, but we don't manipulate them in any way. So I don't know that it is as valuable as some people think it may be. It may be sexy, it may be interesting, but I don't know that microbiology and biochemistry are useful in any way to change how I interact with the patient. Because if there is an assumed microbiological or biochemical alteration for the patient, and I assume that if I go to a particular area and work on that area, that it should change it. Well, I'm not paying attention to the patient. I'm paying attention to an idea that I can't properly sense. If I pay attention to mechanical dysfunction, work on mechanical dysfunction, I got it. I'm doing the right stuff. I'm properly responding to the patient in that moment. So that's appropriate. I don't think it's really useful for an osteopathic practitioner to know those things outside of general knowledge. The ability to connect with what the patient is providing as information from other practitioners. So this is B. I will read now. Clinical sciences, models of health and disease, safety and ethics, pathology and pathophysiology of the nervous, musculoskeletal, psychological, cardiovascular, pulmonary, gastrointestinal, reproductive, genitourinary, immunological, endocrine, and otolaryngology. Otolaryngology. I think it's supposed to be otolaryngology. I don't know. Laryngology? Systems. Going back to reading properly and not stumbling and being a goof. Applied anatomy, neurology, and neurophysiology. Diagnosis, radiology, and laboratory results. Sure. Nutrition, no. And relevant knowledge of pharmacology. Osteopathic practitioners should not be interacting with people's nutrition unless you're a DO. If you're a DO, cool. Otherwise, there's really no jurisdiction in which you're going to be properly equipped to deal with this, more so than somebody who's a nutritionist. You can recognize when somebody's having nutritional issues and refer out. The models of health and disease, well, a lot of those models have problems. So I don't know how many of them you really need to know. I think it's important to know them to be able to compare and contrast, but it gives you a lot to think about in a way that's probably not even remotely useful. So yeah, you can teach them, but you should be also teaching which ones suck and which ones are okay. And even when they're okay, their strengths and limitations would be very important. Yeah, I can move on from that. C, osteopathic sciences, philosophy and history of osteopathy, osteopathic models for structure, function, interrelationship. See Annex A, that's the 5 models. To read again, clinical biomechanics, joint and visceral physiology and kinetics. Again, there's one of the, not reading now, the visceral physiology. There's another one of those, I would say, pathological fetishes in the profession. To return to reading, mechanisms of action of osteopathic techniques and applied principles. Mechanisms of action for osteopathic techniques, good luck. We don't really know them properly in a meaningful way. We make a lot of assumptions. This is where, when you consider something that I've said previous with respect to anatomical possibilism, that relatively recent article based on when I'm recording this, that is in the International Journal of Osteopathic Medicine. Yeah, just because the anatomy's there doesn't mean it explains anything. So I don't know that that should be in this document. The visceral physiology, I would consider it a pathological fetish. The applied principles, yeah. D, clinical skills, obtaining and using a patient history. Very good. Physical and clinical examination. Yes. Osteopathic diagnosis of the nervous, musculoskeletal, physiological, psychological. Osteopathic diagnosis of the psychological. No. Cardiovascular, pulmonary, gastrointestinal, endocrine, genitourinary, immunological, reproductive, and otolaryngology systems. No. No. Just absolutely no. We're outside of the patient. We can't properly diagnose that, especially compared with our current diagnostic methods at the time of recording this. So I'm recording this in 2024. Just no. Osteopathic diagnosis of the patient? Yes. Osteopathic diagnosis would infer that you are providing a mechanical diagnostic of how the patient and their structures move on a gross level. Anything deeper than that, just no. No, you're making interpretation that is not appropriate. To go back to reading, general synthesis of basic laboratory and imaging data. In some jurisdictions, yes. In my jurisdiction, no. I am simply allowed to read whatever they said. To go back to reading, clinical problem solving and reasoning. Fair enough. I won't brag on that too hard. To move on to read again, understanding of relevant and current research and its integration into practice. Communication and interviewing, absolutely. Clinical documentation, yep. Life support and first aid care, yep. And osteopathic treatment and osteopathic techniques, see Annex C. There's going to be just a big long list of stuff, whatever. To read 6.4, osteopathic teaching, learning, and assessment. Do I want to do that? Yeah, I will do that. Teaching and learning. Teaching and learning in osteopathy programs shall take place in combination of the following context. Lectures. They shall convey and comment upon core subject matter informed by evidence, stimulate critical thinking and debate, and encourage students to extend their knowledge and understanding. Okay? The critical thinking, strike that out. Forget that. Critical thinking is not a thing. I've talked about that before. B, workshops and seminars. They may commonly involve small group work, skills development, discussions, and student presentations. C, tutorials. Support the process of self-assessment and tutor guidance and feedback. They may also provide support for individual work and group dissertation preparation. I'm going to pause here. This is all assuming that you're in a particular institutional setting. None of this actually has to happen in the way that this is set out. I think they're saying this is kind of acceptable stuff, but a combination. There's huge amounts of assumptions. This doesn't help from an actual perspective of somebody who knows what the heck they're talking about with delivering education. This isn't necessary, right? Not for an applied field. D, self-managed and self-directed learning. That happens anyways. Sorry, let me read. This is an important part of any program in osteopathy. It may involve preparation for specific assignments, reflection, discussion, practice of osteopathic techniques, and the use of resource-based learning, including learning resources made available in electronic and other formats. It is important that students are adequately prepared, guided, and supported in developing and maintaining effective strategies for self-managed learning. That is a central assumption of a lot of educators that doesn't happen. I don't care what kind of educator you are. Motivated students go home and do it themselves. It has nothing to do with your lecture. Your lecture, especially synchronous lecturing, everybody takes it differently. They're going to go home and figure it out anyways. So I'm going to giggle my face off at this because it happens anyways. Like, that's just such a thing about people, even who do know about education. They don't understand that happens. The gentleman who is probably most well known within health science education that I'm academically related to is Dr. Jeff Norman. Dr. Jeff Norman will always tell you, yeah, motivated students and keen students, they just go home and do it anyways. So yeah, that can go away. Whatever. Anyways, E, production of a dissertation. Students will normally undertake their own individual osteopathy-related research project or study. No, it's not a dissertation. You're using the term wrong. It's not a dissertation. This is not multiple studies coming together. No. A capstone portfolio project, perhaps. A research synthesis, possibly okay. Experiment-based thesis, yes, right? They're not doing a dissertation. No. F, supervised clinical practice. Okay, fair enough. 6.4.2, practical skills. The acquisition of practical osteopathic skills requires students to work on peers and in turn to experience taught techniques as models. Palpation osteopathic techniques shall be taught in specialist accommodation utilizing appropriate equipment. There's no equipment. It's a table. I guess that's equipment. Table and pillows, whatever. Provision for students to review and assess their performance of their osteopathic practical skills through the use of regular tutor feedback in this area is ideal and critical. Yep, that's going to happen anyway. Students are going to give each other feedback no matter what. That's why you lean into near-peer teaching and near-peer feedback. That's why you have people of different levels work with each other. Okay, teaching and supervision in practical osteopathic technique skills is performed by suitably qualified osteopaths registered with a relevant national register or competent authority with a representative association where the former bodies do not exist. Fair enough. 6.4.3, clinical education. It is essential that clinical learning experience provides appropriate opportunities for students to develop not only patient evaluation treatment skills, but also the ability to confidently recognize signs and symptoms indicating the need for referral and contraindications and to specific osteopathic techniques. I don't think you need to write this here. It's already in the document. Clinical learning environment shall be a focus for the integration of practical application of all theoretical, practical, and technical knowledge. Yeah, and skills across the program. It shall provide the student with a supportive, broad, progressive, and well-supervised environment in which to develop their clinical skills. Fair enough. It is expected that the students shall undertake substantial supervised osteopathic clinical practice within a dedicated teaching clinic where they can observe senior students and qualified practitioners in the early stages of their training, progressing to take an increasing responsibility for their own patient lists as their experience and knowledge develop. Following arrangements for osteopathic clinic education are to be expected: adequate, appropriate learning opportunities for developing professional skills with real patients, paying due regard to case history, taking examination. This is already noted. I'm going to skip over that. B, opportunities to integrate academic, theoretical learning and to develop practical skills within the therapeutic clinical encounter. That's already written. C, adequate numbers of each student of new returning or continuing. Anyways, patient encounters. Oh, they mean with the same person. Exposure to an appropriate range of presenting conditions. You can't guarantee a proper exposure to any range of presenting conditions. You can't do that. Not meaningfully anyways. That's a major problem in medical education. Healthcare education is already noted. D. Appropriate staff-student ratios with a clinical setting allowing for close supervision of patient encounters by tutors and opportunities for clinical tutorials. Tell me what those are, please. Appropriate opportunities for junior students to learn from observation. That's already there. It's already there. F, appropriate settings for clinical education with a dedicated training clinic with adequate treatment and educational accommodation, appropriate equipment and furnishings for high-quality student experience and patient care. Yeah, you want sexy stuff. That's nice. G, appropriate clinical administrative infrastructures to support student learning and patient care. Administrative infrastructure? Yeah, fair. H, arrangements for ongoing assessment and feedback from a variety of clinical tutors. Yes. Opportunities to develop practice management skills. Yeah, that's already there. J, effective mechanism for monitoring individual student clinical attendance, caseloads, patient list profiles. Fair enough. That's administrative. So that can fold back into the administrative. K, effective mechanisms for ensuring that high standards of osteopathic treatment and the safety of patients are maintained by guiding, developing, monitoring professional conduct of students treating patients. And L, appropriate opportunities to participate in patient reviews. That's rounds, discussions. Okay, fair enough. The last thing that I'm going to go through, please appreciate that this matters on some level, that this is examined in some way that doesn't include the people that generated this or the groups that generated this. So this may not be the sexiest to you. Obviously, I'm getting a bit of a kick out of it, but that's me and my particular background. So the last thing I want to read through is assessment 6.4.4. Students of osteopathy shall master a wide range of knowledge and skills as indicated above, and they shall be able to demonstrate an ability to integrate and apply their learning. I'm not going to read that. That's already there. Like this, the redundancy in the document. The redundancy in most administrative documents is harmful. Like it's going to hurt the feelings of so many people, and you can't keep up with it. It just generates these giant checklists that make everybody take time. They're make work projects probably completely by accident for people who like administration. It's not on purpose, I don't think. I think the people who tune into this stuff like this stuff. Fair enough. I'm not going to, whatever. Hold on. I'm going to just pick up at the end of this paragraph. A range of assessment strategies shall be employed. These assessment strategies should include A, demonstration of clinical competence in practice, including the ability to draw on, synthesize, and apply knowledge and skills for safe and effective patient management. Methods of assessment may vary, but should always include the requirement for students to demonstrate skills working with a range of new and continuing patients so as to ensure comparability of practitioner standards for entrance to the profession. It is essential that external examiners are physically present at some of the practical assessments with real patients in a real clinical scenario. Workplace-based assessment. That would be workplace-based assessment. There you go. B, practical examinations in which students demonstrate their skills in selecting and performing a range of safe and effective osteopathic techniques. Yep, that's probably the actual one that you need to do the most. Provide the opportunity to show the decision-making and application. C, written examinations under time condition requiring students to work and think under pressure. Usual examination conditions, assessing knowledge base, understanding, and analytical skills. This is an applied field. The problem solving exists and is applied to living people. I don't know that the written stuff is absolutely a requirement, but because people claim that it is, yeah, sure, Do it on your anatomy and physiology and your history and stuff like that. Don't do that on clinical skills. Clinical reasoning skills, just get out of my face with this. If you want to see clinical reasoning, put a person in front of them, figure out if they can figure out how to get through that person in a way that actually makes change. Testing clinical decision-making skills with written frameworks in osteopathy is foolish. No. The answer is no. Don't do that. Dissertation. Dissertations. No. Wrong term. No. Or other pieces of extended written work. These are normally related to osteopathic practice and include systematic inquiry, investigation, analysis, evaluation, shall demonstrate the student's ability to apply appropriate analytical models, whether qualitative or quantitative, to plan and carry out a research project. You can roll that all into teaching the scientific method, teaching the philosophy of science, and requiring people from scratch to generate a experiment-based thesis. That would take care of that. Right? Other assessment strategies and methods that may be employed include portfolios. That's number one. It should be a portfolio. Number one should be a portfolio. It should be a competency portfolio, basically. You should have a bunch of assessment methods that make a lot of data points, which will inform your decision based on consistent demonstration of the appropriate competencies, which I think are far too many in these documents. Any of these documents on education, there's way too many, especially with respect to osteopathy. But yeah, portfolio is number one. The other ones that are initially listed, this is number one. The portfolio is number one. Collating evidence to support claims that learning outcomes have been met. Portfolios may be a means of capturing and giving proper weight to experience and may be used to document the acquisition of practical and or clinical and or affective skills. Why affective? Emotional skills? Okay, anyways, that's number one. The rest of this can be rolled into that. That's the one. B, essays and other coursework which enable students to display a broader knowledge of subject matter than an examination, papers, and test their ability to investigate a topic, to organize their material and ideas to a prescribed deadline, and to critically appraise published evidence. You could do that when teaching the philosophy of science and the scientific method, and yeah, you could do that there. That's fine. Computer-based assessments, yeah. These all could be almost all of these, aside from the clinical stuff, could be computer-based. Case study presentations and analyses, oral presentations, testing, presentation and communication skills in an individual or group situation. F, analytical exercises, including paper patient exercises, no. And objective OSCEs, objective structured clinical examination, objective structured practical examination type assessments. What the heck is an OSPE? I don't know. You could say mini CEX, mini clinical exam. Anyways, yeah, lots of stuff here. You can see that I've agreed with some, picked at some. There's far too many competencies that aren't competencies. There's far too many of the lists that really are the same construct that could be really condensed. There's a lot of repetition in documents like these. These are administrative documents. This is a much more recent document than the World Health Organization document, and the CSA one, the Canadian one, is even more recent than that. I don't have it at my immediate disposal. It does cost money to access, and I have not done that at this particular point. These documents show that the people who are working on them are administrators, not educators. Unfortunately, they lack the technical expertise to understand how to actually develop this. They lack on the educational side as well as on the osteopathic side. Most osteopathic practitioners lack the technical expertise to understand that most of the claims they make about themselves and their profession are pretty big and pretty ridiculous. There also is the reality, unfortunately, that means that you will build educational models and technical models that include all those flaws. There's a lot of flaws in these documents that just don't need to be there. They are way larger than they need to be, even though they aren't large with respect to documents of this nature. But they've got even the assessment backwards. It should be a portfolio. You should have practical examinations, especially formative ones that are for feedback. You are examining skill, but you are providing feedback such that however they do, over the course of time, you see an arc towards competence and then a stabilization of competence. That competence should be based on the fundamental constructs of the competencies of the profession, which should include diagnostics, but those diagnostics should include appropriate ranges of motion, like fully exploring the range of motion so you actually know where the restriction is. Also, the patient shouldn't wince. The patient shouldn't be too far away. There are ways to set these up that are not unfortunately considered here. Now, I have my preferences for these things and I completely acknowledge that, but yeah, this is a lot of stuff that's kind of ridiculous in here. So for those who stuck with me the whole way, thank you. If I have any influence on it, I would hope to be able to do something about the educational documents and the educational models within the profession, because there's a lot of excess on the administrative side that some people will appreciate and other people see as roadblocks. I see them mostly as roadblocks, so I have to acknowledge that that is my preference. For those who are looking to institutionalization for validation, you're nuts. The institutions don't know what to do with you. The institutions don't know what you are. There's just a large amount of paperwork for nothing. It doesn't improve educational delivery, critical thinking programs. Like, what are you talking about? Clinical skills. Well, define what those clinical skills are. Sure, I'm fine with a course like that. Critical thinking, go away. Right? Evidence-based medicine, evidence-based practice. That's just a fancy term for the scientific method and scientific skills. Teach those. Let's move on. Right? And there's much more validated ways to teach those and prove that those are the case. It's an abstract problem-solving framework, so I can tell you once again, a FAR transfer paradigm will do much better for that than a critical thinking class. So yeah, I've rambled a lot. Thank you for listening. We'll talk again soon.